diagnosed patient at the moment. So there is a huge number of that. So they said that we need 900,000 cases per year to treat that, and then at least 700,000 to eliminate this by 2030. So there is a huge, the prevalence or the incidence is huge in Pakistan if we consider the hepatitis C. It's not with the cirrhosis of the patient or with the complication, but it's they're expecting who has the asymptomatic or symptomatic hepatitis C. So now, as you know, that the presentation of the hepatitis, it's most of the time non-specific. As you know that we were treating the patient in our Avicenna hospital, whom we were admitting from 2016 to 2019, end of 18. We were having at least 1,500 patients. All they were asymptomatic. What were their most common presentation? They were constitutional symptoms. They were coming up with the aches and pains, headache, tiredness, fatigue. Very few of them, they were getting fever or like this. So, but when someone has acute hepatitis, he may not think about that he has a hepatitis, because these patients, they will be having fever, they will be having nausea, diarrhea, abdominal pain, and none of these symptoms, they are specific for hepatitis. Very few of them, they present with the jaundice. When they present with the jaundice, they go to the hospitals to see the consultant over there or the doctors in the hospital. Most of them, they end up seeing the GPs. So if someone has the jaundice, then they will repeat the LFTs and they will start diagnosing that. But most of the patients, they don't go in the hospital with the jaundice. So they can present sometimes with the hepatic failure or with the hepatic encephalopathy. These are the patients who present in the tertiary care hospital. And there are a lot of patients who present first time with the hepatocellular carcinoma, because, and these are the people who are elderly people. They do not have any previous diagnosis, and they do not have any previous labeling of the hepatitis C. Now, when I'm talking about the hepatitis C, as the symptoms, they are very non-specific. So what we find, when we repeat the blood, when we check the blood test, we find that there are abnormal LFTs or there is some flu in that. So in medicine, the most fundamental question when you want to request a test is which test you want to request and why do you want to request. Is it just you want to order to see the LFTs, or is it you want to diagnose something? It's very easy because to write out in the emergency slip as well and in the notes as well, to do the LFTs, RFTs, CBC. But if you don't know why you are asking this question or are requesting this test and what you want to expect. So if you will start thinking about why I'm doing this action and you try to find the cause for that, you will be end up becoming a much better doctor and giving the answer in a very logical way. So the aims of investigation in a patient with suspected liver disease is, first is to detect the hepatic abnormality. That is there any abnormality or not? If there is abnormality, what is the grade of the abnormality? So you want to assess or measure the severity of the liver damage. Is it acutely damaged? Is it chronically damaged? Okay, or is it there are complications has occurred? So all these things there. Then you want to, particularly in the liver test, you have to find out what is the pattern of the liver function test. So if you just a minute, I want to ask you that are you listening? Any problem? Okay. Yeah. So if you want to detect the pattern of the liver function, there are three commonly patterns of the liver function test. One is called hepatitis, other is called obstructive, and third is called cholestatic. There is a difference between the obstructive and cholestatic. Obstructive pattern occurs predominantly either in the liver or in the bile duct. Cholestatic occur in the gallbladder and in the bile duct. Because obstructive pattern can occur in the in drugs as well, and when there is a inflammatory pattern inside the bile ducts, which are the microvascular or macrovascular in the liver. So you want to find out from the liver function test, is it hepatitis, which is hepatocellular damage, is it a bile duct problem, or is it problem in the common bile duct. So from depending on that, you will try to find the specific cause for that, and you want to investigate the possible complication at the same time. So just requesting the test, you have to keep in mind all these five things when you are requesting the blood test. So now I will talk about the most common cause of acute hepatitis in Pakistan is hepatitis A, B, all sort of viral hepatitis card. Sometimes we do see amoebic liver abscess. Sometimes we see with the drug overdosage, for example, very rarely paracetamol, and most of them did not. जी
डिस्कनेक्ट हुआ ये
ये डिस्कनेक्ट क्यों कहाँ से हो गया है?
तो यहाँ से लाया शेयर करें दोबारा यहाँ सर यहाँ
गड़बड़ हो गया।
वो वीडियो वाला सर आपने क्लिक कर दिया 1 मिनट सर आप
ये ध्यान से चले जाए। तो पैसा नहीं देख, इसको बंद कर दो।
जी सर वो लेक्चर ओपन करें पीछे करें सर
यहाँ से
सही है
एग्जिट फुल स्क्रीन कर दें।
वो आ गया शेयर कर दें स्टार्ट लेक्चर
ये किससे आप लेक्चर स्टार्ट ये शुरू हो गया ना?
हो गया सर
अच्छा चलें। So as most common cause of the hepatitis is the viral hepatitis, and sometimes you see there is a paracetamol overdosage, or most commonly second one is the amoebic hepatitis or amoebic liver disease. But today's topic is predominantly about the hepatitis. So hepatitis A virus, it is a single stranded RNA virus. Most hepatitis A infections, they are asymptomatic in young children, but they do the older children they do get, and the adults they get the hepatitis A infection. Average time from the exposure to the clinical illness is 4 weeks. It ranges from 2 to 6 weeks, and it lasts for less than 1 month. There is no specific treatment for the hepatitis A, but there is can be a relapsing hepatitis. Sometimes, rarely, you get a fulminant hepatitis A, which can be significantly damaging the liver. But there is no liver residual liver damage once you have hepatitis A recovered. So hepatitis A antibodies, they are protective against the reinfection. Here I will give you I'll show you a graph here. This is you will see a lot of these graphs for hepatitis A, B, C, D, and E. So up to the second week, you will start having the fecal hepatitis A virus antigen in the feces. So it does not occur in the serum, so it's most of the time in the fecal matter. So you will request the stool for hepatitis A virus antigen if you are suspecting hepatitis A before the 4 weeks. So after that, at the 4 weeks time, hepatitis A virus antibodies start developing. IgM, it starts happening early on, but at the same time, hepatitis IgG antibodies also occur. But if someone has a hepatitis A virus antibody, IgM antibodies, it means he has acute infection. But if someone has a hepatitis IgG antibody, it means he has the chronic infection. So that is a good thing that he already has the hepatitis IgG antibodies, and that is protected. So this is, and it lasts up to 6 weeks, and after the IgM, and then it started going down. And after that, hepatitis IgG, they will remain forever over there. So if you want to request a test in first few weeks, you will request for the fecal hepatitis A virus antigen. After that, if it's more than 4 weeks, the symptom occurred. After that, you are going to request the anti-hepatitis A IgG or IgM. Second one is the hepatitis B virus. It is a DNA virus, and it has A to J 10 genotypes. The genotypes, they are different in Asians, they are different in North American, Western, and we need to know that what is the common genotype B virus in our settings. So currently, the hepatitis B vaccines, they are common and they are recommended. They are composed of the recombinant, and they are non-infectious, and but they contain hepatitis B surface antigen particles, so they elicit the anti-hepatitis B surface antibodies. So if you check the blood, you may find if someone has the vaccination previously that he will be having the antibodies against the hepatitis B surface antigen. So thus that vaccinated individual have anti-hepatitis B surface antibodies, they are detected in the serum. Why I'm talking this, I will come back later on. The natural history of that is hepatitis B virus primarily affects the hepatocytes, although viral DNA is detected in the peripheral blood mononuclear cells. Less than 15% of the patient, they will be having clinical hepatitis, and among them, half of these, they will develop jaundice. Approximately 95% of immunocompetent people infected with hepatitis B, they have a self-limited infection, and most of them, they recover completely. Vertical transmission, that is from mother to the baby, it occurs in chronic infections in approximately 90% of the cases. So here is the hepatitis B virus antigen. So there is the surface antigen. There is a double stranded DNA. This is a single stranded DNA for polymerase. And here is the hepatitis C antigen. So whenever we will be discussing a lot about the hepatitis surface antigen, C antigen, and the E antigen. So there are four phases of that. One is called the immunotolerance. Other is called immunoactive disease with hepatitis E antigen positive. Third one is hepatitis E antigen negative inactive disease, particularly inactive chronic hepatitis B or low replicated infection. Fourth one is hepatitis C negative immunoreactive disease. So there are immunotolerance. There will be asymptomatic patient with positive hepatitis B surface antigen and E antigens. The liver function test, they will be normal, but they will be having a high hepatitis B virus DNA. The load will be more than 20,000 international units. In this condition, the enzymes will be normal. Hepatitis surface antigen and antibodies will be present, and hepatitis B virus DNA will be present. In the second phase, the individual may or may not have clinical liver disease at all. Patient will be having positive surface antigen, E antigen, positive or negative anti-hepatitis B, E antibodies, but their enzymes will be raised more than 2 times the upper limit of the normal ALT. They will be having again hepatitis B virus DNA load that will be more than 20,000. In this, the virus load is more than, but the liver enzymes, they are normal. Here, the liver enzymes, they are increased along with that. With the hepatitis surface antigen positive in both the conditions, but hepatitis anti-B antibody, they can be positive. The hepatitis E negative, this is the third stage in which hepatitis B surface antigen will be negative. In contrast to these previous situations, here the hepatitis B surface antigen that will be present, but negative hepatitis E antigen, but positive hepatitis E antibodies. Liver function test will be normal, but the DNA viral load will be less than 2,000. So the problem is that this is the cutoff value which is used for the hepatitis B. We do not see in hepatitis C or in other hepatitis. So this it contrasts with this stage where there will be negative hepatitis B surface antigen, but hepatitis E and anti-hepatitis present, but in liver enzymes will be increased to the more than twice the normal. There may be fibro from previous inflammation, but not complete. And here the range will be more than 200,000. Here the range will be less than 200,000. So this you will remember is just to give you the idea, because when you will be start treating the patient or seeing the patient, seeing the reports, then you will be having a greater knowledge. So symptomatic patient may present with the pre-icteric stage or prodromal period followed by the clinical hepatitis that typically occurs 11 to 24 weeks following that. It means they can have up to 6 months these symptoms, not like hepatitis A where you can get it up to 4 weeks or 6 weeks. In those with the clinical illness, symptoms generally improve by the time jaundice develops, particularly 2 to 6 weeks after the peak serum hepatitis B virus DNA level. In acute self-limited infections, hepatitis B virus DNA and hepatitis sulfur generally decreases below detection limit in the first 4 months after the infection. So there is no point doing the hepatitis B virus DNA or hepatitis B surface antigen, because you will not find them in the lab, in the blood after 3 to 4 months, but you will try to find the hepatitis antibodies. So here there is a window period when the hepatitis surface antigen will not be present, but the autoantibodies will be present. That is called the window period. So if you look at from here, hepatitis surface antigen comes up, then hepatitis B core antibodies come up, then hepatitis after that core antibodies develop and hepatitis surface antibodies develop. But between the hepatitis surface antigen and when they are negative and hepatitis IgG antibodies, they are negative, what you can find is only anti-hepatitis B core IgM, not IgG. So in this situation, you will try to request the hepatitis B C IgM. So it is very interesting phenomena that what you want to look at that and what you want to request to the laboratories. So along with this, the serological evaluation, the first antibody against the core protein, it switched from IgM to IgG in 3 to 6 months time. Measurement of the total anti-hepatitis C determining IgG, IgM core isotype is the best marker for documenting previous hepatitis B infection regardless of their serological results. In acute self-limiting infection, surface antibody detector after surface antigen clearance and appearance of anti-hepatitis C IgG. Surface is generally detected within 6 months after the infection and is a marker of protection against reinfection if someone have the hepatitis surface antigen detected. So in chronic condition, you will see the hepatitis surface antigen that can be positive, but anti-hepatitis IgG core antibodies, they will come back, but the core antibodies, they will last forever. So hepatitis surface antigen and anti-hepatitis C core IgG antibodies, they will be there, So in short, to conclude that here is the how to interpret these patterns. If someone has acute hepatitis B, hepatitis surface antigen will be present and anti-hepatitis B core IgM antibodies will be present. Hepatitis B virus DNA will present, but anti-hepatitis C core antibodies can be present, can be negative. So if you are expecting acute hepatitis and you have the full picture, look for the hepatitis surface antigen and hepatitis B core IgM antibodies along with the virus load. If someone has a past infection, he will be having anti-hepatitis B surface antigen and anti-hepatitis B core antibodies. Sorry, anti-hepatitis B surface antibodies and anti-hepatitis B this core antibodies. So S and surface and core antibodies will be present in the post-infection. All other they will be negative. If someone has a vaccination done, he will be having only anti-hepatitis B surface antibodies. Rest of them all will be negative. And if someone has a previous infections and he has a occult hepatitis again, which is going on, in that situation, he will be having anti-hepatitis B core antibodies and hepatitis B virus DNA. So this slide will give you a good idea that how you are going to infect, because if someone has the acute hepatitis and he has the previously vaccination as well, so his picture will be different. And if someone has a past infection and he does not have acute infection, this picture will be. So this is the most complicated area regarding interpretation of the viral biomarkers in hepatitis serology. Now, regarding the treatment, what will you do for that? This is, though it's not at your level, but just to give you an idea that there are one, two, three, four, five, six. There are six targets. Along with that, these are the immunomodulators where you are targeting for the treatment. Either you block the entry of the antigens into the cell, or you inhibit the protein translation by the RNA, or you inhibit the DNA silencing, you inhibit the core inhibitors, you didn't inhibit the polymerase inhibitor and hepatitis B surface antigen release inhibitor, you attack them, or you attack these cells, natural killer cells, macrophages, cytotoxic cells, and then B cell, T cell, all these. So these are the potential markers for the treatment for the, and a lot of work is done is going on them. Again, in the next slide, see again, in future, they are going to do the combination of that. They will inhibit viral replication. They will try to lower the viral antigen burden, and they will boost the immune response depending on attacking on these cells. So as we know that the viral burden, as nowadays there is a COVID infection going on, so people a lot talk about the viral burden of the COVID virus because it is more in the droplet infection as compared to the where you have the direct contact, like hand with the hands from the clothes. So the viral load is very, very important in the viral infection. So therefore, they are attacking the viral load as well. Now I will come back to the hepatitis C virus. Hepatitis C virus is a single stranded RNA virus. It refers to acute hepatitis C infection, refers to the when the patient develops the symptom up to 6 months following the getting of the infection, regardless of the symptom, whether his symptom stays or his symptoms goes away. Infection is usually asymptomatic despite abnormal liver function test results. In symptomatic patient, most patient presents with the non-specific flu-like illness. As I was telling in my opening slide, that these are the non-specific symptoms with which patient go to the general practitioner, doctors, in the even the to the medical stores as well. They give them some painkillers or anti-inflammatories, and after that these symptoms goes away. But he does not know until we investigate those. A minority of infected individuals develop symptoms of acute viral hepatitis, including jaundice, anorexia, and abdominal discomfort. And when someone gets the jaundice, then we go to look for the investigation, checking the lefties, and we find that he has an acute liver injury. It is incidentally, we found sometimes the abnormal liver function test, like when a patient comes since the started of the hepatitis C, this screening test, and we were giving the in Avicenna, we were giving free medicine to the people, and we advertised on this cable network. You know, a lot of people, they were coming to us and they were saying, I want to do a blood test for the hepatitis C. Why? Because they knew that they're going to get a free medicine. So what they were saying that when they're coming to us in the outpatient, they were saying that we want to do the test. What does it mean? They want to check the liver function test, hepatitis C, and the ultrasound of the abdomen to find out whether they have the hepatitis or not. And a lot of people, we did find some finding on the ultrasound. Some of them, they were having abnormal liver functions, and some they were having normal liver function, but their ultrasound shows that they were having a moderate to severe disease, and all of those patients whom we suspected the viral hepatitis C, when we did the screening test for the hepatitis C, that was positive. So therefore, when you check these patients who has not the finding, you check C abnormal liver function test, and you should have the suspicion for the hepatitis C, because these patients, they have been asymptomatic and they don't remember at all, most of them, that they had any jaundice or they had any these non-specific symptoms or not. But a lot of these patients, they come when they are in the stage of the cirrhosis of the liver. So these are the people who have the worst prognosis. Not everyone with hepatitis C, as you know, that will necessarily develop cirrhosis, but approximately 20% do so within 20 years. So they are going to get the 20% within 20 years. So it is not a uh, it is not like acute infection which was causing the damage to the liver acutely. Therefore, we were having a huge number of hidden population, as I showed it in the first slide, that there is nearly 9 lakh people with the asymptomatic liver disease which is present in Pakistan. So these are the, I think these slides has repeated. So along with that, what you do, you are going to test this ALT and AST, which are the most frequently test requested along with the cholestatic picture. So ALT is present in the hepatocyte, but AST is present in the cytoplasm and the mitochondria of hepatocytes both. So among them, ALT, as you know, that it is outside of the liver is low, and this enzyme therefore called as a specific enzyme for the hepatocellular damage. So if there is the ratio, increased ratio of ALT to AST in the liver function test, it means there is a most likely hepatic injury. But if there is a more AST as compared to ALT ratio, in that situation, he may have from the other places. So large increase in the aminotransfer activity favor hepatocellular damage, and this picture is called the hepatitic picture, as compared to the cholestatic or obstructive picture, which is very used, a famous word in the clinical medicine. So other if someone has a raised liver enzymes, and as I was telling that you need to I will go back to this slide, that you want to detect the hepatic abnormality, you want the severity of the liver damage, pattern of that, and identify the cause. For that, and you want to look at the complication. For that, you are going to request other blood tests. What are those tests? Among the most important is the serum sodium level, because hyponatremia occurs with liver disease due to the increased ADH. Hyponatremia is a significant clinical problem in liver disease. If someone has a raised serum uric acid level, it means there is a gastrointestinal hemorrhage, because most of the time serum urea will be reduced in the hepatic failure. But if someone has the raised urea, always considered for the intestinal hemorrhage. When there is a high level of urea with the raised bilirubin, with the raised serum creatinine, and low urinary sodium, this suggests that this patient has a hepatorenal failure, which carries a grave prognosis. So these are the tests which you can do it very cheaply. You can do it very cheaply, and these are the serum urea, bilirubin, serum creatinine, and low urinary sodium. But keep in mind that the hyponatremia is very common in elderly population, so there are a lot of other causes which lead to hyponatremia. But if you see this picture altogether, then you will consider the liver problem. And along with that, there is a significant elevated ferritin that suggests the hemochromatosis. So, but serum ferritin, keep in mind that it is an inflammatory marker as well. It does not give you, if someone is acutely sick, do not suggest that that he definitely has hemochromatosis. As we are seeing a lot of in the current scenario, a lot of COVID patients who are going on the ventilator, they have a very high ferritin level. So that is an inflammatory marker which is showing not rather than hemochromatosis. Then in the inflammatory conditions, there's among them is non-alcoholic fatty liver disease is common and alcohol abscess is common, and serum ferritin level is increased in these two conditions as well. So if someone has the non-alcoholic fatty liver disease or fatty liver disease, simply in our state, and you want to rule out that he does not have the fatty liver inflammation, check his serum ferritin level. Because nearly, I would say that more than 90% of population, general population, has the fatty liver in Pakistan. And if you want to target it, that who is having the persistent inflammation in the liver, or who is not having checked the serum ferritin, if the ferritin is normal, it may he have the fat accumulation, but he may not have a persistent inflammation going on. Now, so here the interpretation of the laboratory tests, they are straightforward as compared to the hepatitis B. Like if someone has the hepatitis B negative, but hepatitis C, sorry, antibodies they're negative, but hepatitis C virus detectable, he has acute hepatitis C, but he may have a chronic hepatitis C, immunocompromised or exceptional cases where he did not develop the autoantibodies. Antigen is there, but he did not develop the antibodies because of the immunocompromised situation. So in that situation, you can consider that he has a chronic hepatitis. But hepatitis RNA positive, but antibody is negative, acute hepatitis. If antibody is detected, but RNA not detected, he have a spontaneously resolved or treated infection. But his RNA will be negative, but antibodies will be present. So he has been treated or spontaneously resolved infection, mean he does not have a persistent infection going on. If someone has both antibodies detected and both RNA detected, he has a chronic infection. Along with that, he may have an acute on chronic infection, that's what we call it, that clinical history of exposure may have to distinguish. That so he may have a chronic infection and acute infection both. So the condition here will call acute infection or acute on chronic infection. So in that you will detect both of them. But if someone has negative anti-hepatitis B antibodies, negative RNA, no evidence of hepatitis C infection. So if you compare it this slide to the previous hepatitis B one, there is no interpretation, or there is no involvement of the hepatitis C antibodies or hepatitis RNA in the title. It has no role in that. If someone has the positive, it means you have to treat that, not like hepatitis B. So you do not have to stratify in hepatitis C. You have to treat everybody who has hepatitis C, uh, whom you see that his RNA is detectable. So if you do not treat, what will going to happen? Cirrhosis can happen, but if someone has the cirrhosis, there are 5 to 10 years survival rate is 95% and 81% respectively. It means after 5 years, 95% will be alive, and after 10 years, 81% will be alive. 1/4 of these people with cirrhosis will develop complication within 10 years. So if someone has a cirrhosis and he is not treated, he will going to develop the complication within 10 years. Once complications such as ascites develops, it means that their mortality rate has gone down to 50%. That he will going to die within 5 years of the ascites development. But once cirrhosis is present, 2 to 5% per year will develop primary hepatocellular carcinoma. So if someone has ascites, someone has cirrhosis of liver, among them the incidence of hepatocarcinoma will be way up. And I think the chronic hepatitis C infection or chronic liver disease, they will be going to discuss. I think Professor Vaisa will discuss this, so they will explain in detail a little bit more. This is the hepatitis C code. There are, so again there is a code, there is an envelope, and there is this just to show that what's up. So it is there are non-structural protein and there are structural protein. So like NS1 was a non-structural protein, that was the N1H1, but in the other there is structural protein as well. So they are the culprit as well. In some of them they are without the structural ones, and that they are non-structural. So I will leave it here from that one. Risk factor for the acquisition of the hepatitis C infection. Intravenous drug abusers, 95% of the new cases in UK. So in UK, predominantly, it is not the source of spread of infection is the drug misuse, who are using intravenously, not orally. Unscreened blood products. So these two they will be very common in Pakistan, but since we have started screening this, the incidence of this unscreened blood product has gone down, but still it is there. Vertical transmission around 3%, needle stick injury in 3% of the risk, but this is very common in the hospital setting, and again it depends upon how much strong you get the needle stick injury. Then there is iatrogenic parental transmission, for example, contaminated vaccination needles. If you have given one needle to one patient and then you give to the other, there are chances they come. And sharing toothbrush and the razor, it also increases the incidence of hepatitis C. Be careful that if you use the razor of your friend who may have a hepatitis C infection, you do not know, because his infection has resolved, his acute stage has gone, he doesn't remember, but you can come across with by using toothbrush and the razor, particularly razor, uh, because sometimes when you are in urgency and you don't have it and you can miss, you can use a lot of people, male students, they try to use the razor from each other. I don't know what's the situation now, but previously it used to be. So, so be careful about that. Now it comes to the hepatitis C infection. It is caused by the RNA virus that is endemic in India and the Middle East. If it is endemic in India, so it will be endemic in Pakistan as well. So this is again the most common one, even before hepatitis B or hepatitis C in acute infections. The clinical presentation many hepatitis C are similar to those of hepatitis A, but the spread of disease is from the fecal oral route through contaminated food. If your food is contaminated with that, then you are going to die. So this hepatitis C, we have to be very careful among the people who works in the cooking department, in the hostels, in the house, in the large places like hostels as well. So it presents as a self-limiting acute hepatitis and does not usually cause chronic liver disease. Clinical presentation of hepatitis C infection is similar to those observed with other form of that. Although hepatitis seems to be more severe compared with hepatitis, and prolonged cholestasis has been described in significance of the number of patients. The liver function test, why I put this slide, because in that the ALT is typically more than 1000. So it gives you a high titer ALT level at the time of diagnosis. So if someone has acute infection acutely and his liver enzyme is way up, not like 2 times, 3 times, it's more than 1000, always suspect that he will be having acute hepatitis E viral infection. So here is the again attitude from the fecal oral route. So here fecal hepatitis C virus, blood hepatitis D virus you do. Here you can find the only hepatitis E virus IgM antibody. They occur after the second week, and after that they goes down unto 60. But if someone develops anti-hepatitis E virus IgG antibodies, that will be lifelong. So in that there is no antigen test. You find the autoantibodies in the blood or the fecal. But sometimes you see fecal hepatitis C antigen in the virus antigen in the fecal if you check it early on, and that will be within the probably within the 2 to 3 weeks. But if you check both of them, you come to know whether he has acute infection or not. So here is a little bit about the hepatitis anti-hepatitis D virus antibodies. So here is this is the time exposure from the start, even before the hepatitis D virus antibodies developed. There is the hepatitis DNA virus present in the circulation, but the IgG and IgG antibodies again, they become the same time. If someone gets a hepatitis B virus infection, always suspect that he will be having, or most likely will be having, hepatitis C, hepatitis B this infection as well. So D most of the time does occur with the hepatitis surface, there's hepatitis B infection as well. So in that you will be looking for both of them, because hepatitis B virus will improve, but hepatitis C virus will stay, and you have to treat those people with that. So again, there is another slide here, anti-hepatitis B virus antibodies. I put this slide, I looked at from the one of the journal. So from there, I gave you these slides so that this is very important, because clinically, I do not find this one in Davidson or in the Cecil or in other books. So this will be helpful, that when you are expecting, what will the with the time period, which test you will be expecting, you cannot understand or you cannot remember it with one presentation from me. So you have to look at that. And the most important thing in the acute hepatitis, when you go back to your book of Davidson, read their tables carefully and read their figures carefully. If you read those figures, read those tables, and you have a proper understanding of this one, I don't think that you will be having any difficulty in remembering the hepatitis, or clinically using the hepatitis serology in the clinical medicine when you will be seeing the patient in the outpatient department particularly, and the patients who are admitted with the in the hospital with the acute hepatitis. So I will finish it over here, and I will be waiting for your questions. So now I'm opening the chart. Yeah, this chat, sorry, and you can ask the questions. So first of all, give me the honest opinion. How is the presentation? Hepatitis B and C is both of them, they are acutely leading to hepatic encephalopathy, one thing. But hepatitis C, I would say, is a very seriously silent killer, because what happens that a person is spending his life, and all of a sudden they find out that he has some abdominal symptoms, and when they investigate get that this they find that he has hepatocellular carcinoma. So at that when it develops at after that the prognosis is very poor. So in acutely, hepatitis B and C both are very dangerous. But hepatitis C is a silent killer because it does not give you the time and when it causes hepatocellular carcinoma. So be careful. Therefore, we are trying to screen a lot of patients with the hepatitis C, C as well, because these are the silent killer. For example, I when I came here in 2014, I saw a heading of the newspaper on the board in one of the private hospitals that every year we have the 6 lakh patient with the hepatocellular carcinoma. And if you look at in Shaukat Khanam Hospital, really there is a huge number of patients who has hepatocellular carcinoma, and there is no treatment at that stage. Therefore, WHO launched this hepatitis C virus treatment so that they can prevent that. And as you know that you can read it, I didn't concentrate on the treatment for that because you can get it in the chronic liver disease. But in Pakistan, the problems are different. Nearly a lot of patients who are on the dialysis, they can get hepatitis B and hepatitis C again. So our mortality is way up as compared to the other countries. But in acute setting, hepatitis E, if it causes severe damage, then it can lead to hepatic encephalopathy, but more so hepatitis B and hepatitis C if someone gets the acute infection. So hepatitis B vaccination का duration कितना है? So if someone has a hepatitis B vaccination, so if you need to give a booster as well, sometime up to 5 years, depending upon the title. Otherwise, once it's in fact this what we call it's the vaccination done, it is helpful for many years. We could not get the vaccination for the hepatitis C, and because it is not the problem in the European countries. So therefore, we're trying to get the hepatitis C vaccination, but they got more quicker result, the therapeutic medication. So therefore, they are not concentrating at the moment to develop, though the research is going on to develop a vaccination for that, but it is not as quickly as for the like for the COVID. Everyone is thinking to give the hepatitis this the vaccination because it's not a major problem in the Western world. So we need to think about that hepatitis C vaccination as we are spending more our resources on COVID, so we need to think about hepatitis C as well. Ask other questions. Yes, in hepatitis C, very good. Hepatitis C, a lot of, I mean, not a lot of patients, some people, they do get cryoglobulinic vasculitis, and there is another polyarteritis nodosa associated with the hepatitis B, but cryoglobulinic vasculitis is predominantly with the hepatitis C. So vasculitis is along with the hepatocellular carcinoma, vasculitis is a major issue in the hepatitis. Uh, is hepatitis D plus E, both together, I am not aware of that. But hepatitis D with hepatitis B is common, and hepatitis C on its own is common. But there is no, I haven't heard of hepatitis D and E. Gastroenterologists can give you a better answer. So outside of the liver is the vasculitis which can cause these problems. Can present with the cryoglobulin vasculitis, all polyarteritis nodosa with that. Hepatitis A infection which someone has autoantibodies developed, and that will be forever. Hepatitis C and treatment and its duration. So there are a lot of combinations. There are the direct acting agents like sofosbuvir, then there is a veltasavir, then there is a veltasavir, then there is another one. There is a combination. Initially it was with the interferon, but now interferon is absolute. So direct acting agents, they are giving it for 6 weeks. Now they are bringing it to 4 weeks duration. Initially it was for 6 months, then it came for 3 months, then it's 8 weeks. Now they're 6 weeks. They're thinking of that, and hopefully that the treatment for hepatitis C will be of short duration. Hepatitis is totally curable. Yes, it is. It is, but the problem is that you cannot control the infection wholly with the treatment. The reason is some of the patient, because it depends upon the genotype as well. So there are the six genotype is two or three is common in Pakistan. So depending upon that, and other thing is some people they may not tolerate the treatments. They develop a reaction to the medication. So therefore there are there are some problems while treating any infection with the same treatment, because every drug does not work with every patient. So therefore, we need the combination of that. And it's not a. I'm not. I was once I asked one of our friend of in the gastroenterology that is there any gene mutation from the like 3 to 2 or 2 to 1 or something like that. He was not sure about that. But maybe that if there is a gene mutation, then it can be more complicated. But at the moment, we have a very good treatment for hepatitis C, and it is nearly curable at the moment, but not 100%. So this latest available treatment for hepatitis B superinfection. So, but superinfection, this superinfection or superbugs, they are used for the bacterial infection, not for the viral infection. So this is for the bacterial, because you see one bug, and then it is resistant to the one treatment or two treatment or three treatments. Then we call it for the super bug. But it's predominantly viral infection. You don't say we say that there is a gene mutation with that treatment is becoming resistant. And secondly, bacterial infection you do get with the along with the viral infection. So are you going to sleep now? Well, the PEG information, actually the treatment, for the hepatitis B, you need to treat that. But once someone has the hepatitis B infection and someone has the hepatitis B, you need to treat the hepatitis B, because as the antibodies develop forever for against the hepatitis B, then you don't need to treat it, but you will treat the hepatitis B. So last two minutes left. So if you have any question, that's fine. So when is your last lecture? The next lecture? So now I will ask the last question. So when do you think that the Pakistan or your prime minister will take off the lockdown? Estimated time? End of May. Are you sure? One of the professor from he is a Muslim. His name is Ali, I think, and he said that even New York or America, they can take off the lockdown from 4th of May, where there is so much mortality and everything. So you think we can take it from that, from 4th of May? We call you back in the college. Okay, thanks very much, everyone. Okay.